all of you. I welcome you all for this webinar on neuromuscular SIG. As you all know, we finished the first cycle of webinars by all the SIGs. We are entering the second cycle. And today we'll be having guest lecture by Dr. Vida, and then we'll have two case discussions. I'll discuss our president, request President Dr. Chapali ma'am, to introduce the speaker for today, the experts and the monitor for today's session. Over to you, ma'am.
Thank you. Welcome all to the second cycle of the SIGs. Earlier, we were having weekly webinars. Now we will be having fortnightly weekly webinars from now on, every 15 days. So first, third, and fifth Wednesdays would be of the SIGs. And in between, as the case may be, we may have something contextual, which may not be related to the SIG. And we may have one of the days. So we start off today and we'll be talking. Can I have the slide, please, Smita? So we are going to be starting this time on inflammatory myopathies, which is very commonly missed and confused and misdiagnosed. So that is how we go ahead with it today. And Professor Veda Narayanan, who had initially in the first cycle also, was kind enough to have taken a talk. He's Professor of Neurology and Pediatrics, Director Division of Neuromuscular Medicine in University of Texas at Austin, Texas. And he has special interest in neuromuscular disorders, and he's Fellow of Royal College of Physicians, Canada, and Fellow of American Academy of Electrodiagnostic and Neuromuscular Medicine, and member of American Academy of Neurology and Child Neurology Society. Thank you so much, Dr. Veda. And as we have been having experts from different resource settings and different specialities and specializations. So our expert, today we have three experts. First expert is Professor Uluk. Yes, I'm not sure if I'm pronouncing the spelling all right, the name all right. Forgive me if it's wrong. Professor of Pediatrics, Head of Child Neurology Department, Dokuz Eylül University School of Medicine, Izmir, Turkey. And he has over 300 scientific publications, international as well as Turkish. And he's a professor of the Dokuyu Eylül University and associate professor, Ankara Military Academy. Welcome you, Professor Uluk. Then we have Professor M.C. Sharma, who is a very senior professor of neuropathology, and he basically, was the one who started and expanded the muscle, the myology part in the pathology in our department, and he has over 563 publications and 25 chapters in books, and he has, basically been working so much on myology, and currently also has a postdoc who's working on inflammatory myopathies, his own postdoc, his own PhD student, sorry. Welcome, sir. And then we have another colleague, very dear colleague, Professor Rohit Bhatia, who is a professor of neurology. So he's in adult neurology, and I think they see these cases more. And he has more than 200 publications, and he's written textbooks of emergencies in neurology and clinical practice of MS. And he's got a lot of awards, including from stroke from the AAN and INA, and he's on board of many bodies, including he was president of the Indian Stroke Association. Thank you, Dr. Rohit, for joining. So we have wide spectrum of experts, and the session will be moderated by Dr. Renu Sudhar, who is assistant professor at PGI Chandigarh, and she has interest of neuromuscular disorders as well, and has more than 198 publications. Renu, over to you.
Thank you, ma'am, for your kind introduction. So I'm glad, and good evening to everyone. I'm glad that now we are starting the second session of neuromuscular SIG again after a very successful first year of all SIG sessions. So for the first talk, we have Dr. Veda Narayanan, who will be speaking on idiopathic inflammatory myopathies, pathogenesis and treatment. So I welcome, sir, and we are all eagerly waiting to listen to your exciting talks.
Sure. So I can just push okay. Let's share. Can you see my screen, ma'am?
Right, sir.
Not yet, sir. You can reshare your screen.
Okay, share my screen. can you see
Yeah.
see it now, sir? Okay, good.
Yes, sir, it's visible.
All right. Thank you for this opportunity and very good evening to all of you. Thank you, Dr. Gulati, and thank you, Dr. Kamte, and also thanks to all the moderators and the experts in this group. I'm kind of humbled to be in your presence. You guys have a remarkable amount of more experience, perhaps, in this field. So what I'm going to do is I'm going to go over, it's more as a general review as a pediatric neuromuscular specialist who comes across this problem, and also to kind of highlight some of the new concepts that have been coming up, especially in dermatomyositis and in terms of the pathogenesis, which is now translating from that into other forms of meaningful treatment approaches. So this will be kind of an overview and not really in-depth in any particular area. So inflammatory myopathies, as this group can very well recognize, is by far one of the most common acquired muscle disease. But in general, it is quite uncommon in practice. But amongst the acquired disease, this is by far the most common. And it is characterized by onset that's usually slow, and it's a progressive muscle weakness. The big issue with this is not to miss the diagnosis because it's treatable and it can be treated quite effectively if recognized appropriately. And also, what has happened is of late, we are recognizing that, or even in the past, much more, is the clinical features and the pathology also can be challenging with a lot of overlap features with myopathies of genetic origin, so which can perhaps lead to people who do not have inflammation ending up with treatments. And so the need for accuracy in diagnosis has really come up as we are getting into more and more focused and more aggressive treatment approaches. And one of the things that has borne out in the last 2 to 3 decades is that the mortality and morbidity, especially in childhood inflammatory myopathies, has come down to a significant extent, but it's still quite a reasonable number where, up to maybe 2 to 3% of children with severe forms of inflammatory muscle disease may die. And similarly, if you look at about 3 years into onset of diagnosis, the general remission rate is around 40 to 50%. So you still have a sizable number of these children who would be suffering from this problem and need fairly chronic treatment, and along with it, of course, the side effects that go with it. So my learning, what I'm going to address this time is really principally the classification of inflammatory myopathies, what we currently use, how it has changed some in the last few decades. We'll talk about how this subtypes are underclassified based upon their clinical pathology and most importantly about the serological findings, which has become very important these days. We'll briefly touch on risk of malignancy because it's not a major issue in the pediatric age group, and also talk about treatments that are available and general prognosis. We'll try to wrap it up with that. So the main focus is really in terms of recognizing this clinically and also addressing some of the issues in terms of the pathogenesis that we have learned in the past decades. So in the past, or even now, we can divide inflammatory muscle disease into subtypes. And this is the way I usually conceive in my practice. So there is the big chunk, which is the idiopathic inflammatory myositis. We'll come to that in a minute. And along with that, you also have other secondary or muscle disease. You can see this in sarcoid and it can have a lot of overlapping features. Now, I'm not going to talk about inclusion body myositis, which is a major muscle disease in the elderly, and it can be quite challenging in terms of treating these people. Then there is this group of viral and post-viral myositis. We have generally recognized myositis, especially sometimes severe forms of this with influenza and sometimes with Coxsackie B infections. But of late, the COVID virus has brought up the interest. There's several publications of viral myositis, even with rhabdomyolysis, which is profound muscle breakdown in the context of with and following the COVID infections. We have also had experience in treating myositis with West Nile virus, which has a lot of similarities with dengue. And of course, myositis is also a component with HIV and with HDLV disease. But overall, they sort of come up as sporadic, interesting problems, but not as frequent as the first one. And then you also have the group of parasitic myositis, which overall in our practice is not very common, but we do keep that in mind, especially if eosinophilia is a big component. We have seen some with toxoplasma infections and also rarely with with other sort of parasitic infection, but it's not a major issue. Now, idiopathic inflammatory muscle disease, it was, Peter and Bohan in 1975 in their paper in New England Journal tried to sort of attack this problem. They tried to sort of come up with a working diagnosis to really, as a process of how to identify polymyositis, dermatomyositis, and to separate them. This came up as one of the first attempts to initiate therapies and follow-up studies. I'll come to this in the next slide. But as of now, with the advances which have come through, and also the recognition that Peter and Bohan's criteria have a lot of shortcomings. So we kind of think about idiopathic muscle disease in the following subgroups. You have dermatomyositis. We'll talk a lot about it. We identify a juvenile form, which usually childhood. And then there's an adult, usually, which kind of comes up in between around 35 to 50 years of age. Then there is anti-synthetase syndrome, which is very distinct with features that can be identified both on serology, some clinical features, and also on pathology, and also has a distinctly different prognosis in terms of response and morbidity. Then we have immune-mediated necrotizing myopathies, and we also have inclusion body myositis. Now, overlap syndrome is where you have features of other collagen vascular disease. Most often it is along with dermatomyositis-like pattern, but it could be with polymyositis. And you also get myositis with mixed features in the context of vascular disease. Typically, lupus, in some studies, we do see it is a significant complication in the population of patients with lupus, especially young adolescents and young adults. And of course, now with our colleagues in oncology, with their success in treating advanced cancers using checkpoint inhibitors, we are now seeing a new group of this myositis problem. And this typically or many times will occur along with features of myasthenia gravis also. And it has to be recognized and treated because it could be challenging. We also have started seeing this, I'm going to add to this, is that you could get a severe form of myositis with gene therapy for for Duchenne muscular dystrophy. There are a handful of patients, not many, and that is also secondary to the same activation of the immune system against a antigenic profile that the body hadn't previously. This typically happens in children or adults who get the gene therapy where they have absence of exons 8 and 9. So, but it can also happen in other settings. So our spectrum has increased, so we now have more distinct subgroups and they have to be treated differently. So coming down to Bohan and Peters' criteria, so they identified that myositis in general is a subacute disease, symmetrical proximal muscle weakness. It still kind of goes, so you get the characteristic difficulties of, trouble with raising your arm, getting up steps, walking, which we typically call hair, stair, and chair difficulties, so which is weakness in these settings. It's not very specific other than that. Pain is generally not a big issue, and most of the inflammatory people do complain of some discomfort. Elevated serum kinase can be variable. It can be from 2 to 3 to, sometimes even 50 to 100 times of the upper limits of normal. Typical EMG, which they really mean that you would see small, sharp motor unit potentials, and then changes in muscle biopsy, which is really the anchor of necrosis, regeneration, perivesicular atrophy and dermatomyositis, and inflammatory exudates around intact muscle fibers in the polymyositis group. Typical rash in the dermatomyositis. So if you had 3 out of 4, you could usually make a diagnosis. And then you excluded the consideration that if there is slow progression, if there's a family history, if there is indication of other neuromuscular life. But there are a lot of problems. This doesn't quite fit. Some of the features may not be there. Rash may not be present in the typical pattern. Slow progression cannot exclude all forms of inflammatory disease, as we will talk about. And so this has led to, in the past, 2 to 3 decades, a lot of studies by our rheumatology colleagues, and pretty much now the accepted form is in the idiopathic. You divide them into these broad groups. So coming to dermatomyositis, it is a acquired inflammatory disease where you have both muscle and skin changes. It is, at least in the pediatric age group, it is one of the very satisfying and treatable neuromuscular conditions for people of my specialty. So as we talked about, there are 2 peaks. It happens in adults and in children. They both are kind of mutually exclusive, and there are some features that are different in terms of the accompanying other non-muscle disorders, risk factors, etc. Annual incidence, as you can see, is not very high in the adult group, and from the Rochester group in Mayo, it's about 1 per 100,000 or less. And then the juvenile is much less, 1/10 of that. So really, it's quite uncommon. In my experience, I've taken care of about 50 to 60 over many years. And it's interesting that at least in the pediatric subgroup, quite frequently you would encounter antecedent respiratory illness or GI illness. These are some of the numbers that are quoted in 60% for respiratory complications prior to, and 30%. So this actually brings up the question whether these viral illness could possibly set the scene for the onset of inflammatory muscle disease. The typical ones that are considered are Coxsackie, and also some of the enterovirus in the GI illness group, and also mycoplasma is thrown in the middle of this. And then in terms of the other factor is ultraviolet exposure. It has been there is association that dermatomyositis especially tends to occur more often as the latitude goes up, so indicating that you probably get more UV radiation in those places. Typically, the culprit considered is the UVB rays. And there are an interesting TNF a gene variant, I don't remember the number, but that apparently allows the keratocytes to make a lot more interferon-like molecules in exposure to ultraviolet. So clearly, in a sense that, that is a factor. And clearly, UV exposure is an important factor when relapses take place. There are many instances where you would say that, going out in the beach without proper sun protection is a trigger for a relapse of symptoms. The muscle weakness itself is not much different than what we talked about. It's a hair, chair, stair pattern. And usually distal muscles are not affected to a great extent unless it's very, very, extreme. And the rash can be quite challenging at times in the early stages. It can be often confused with eczema or other types of dermatitis. It's not very uncommon to see children being treated with steroids and other medications, creams, for a while under the presumption, especially when they don't show much in the way of muscle weakness. And so the typical ones are scaly erythematous rash on knuckles and extensor surface, face, and anterior chest. I have some pictures in the next slide to show you their example. Then there are these raised nodules, which can look either red or it can be pale, depending on their stage, which calls Gottron's rash or Gottron's nodules. Gottron's rash is, it's a sign of more active illness. Now, there is variable amount of systemic symptoms in children, especially. We do see some with GI involvement, and then there are some of the subtypes where GI involvement is prominent in the form of ulcerations and vasculitic complications. The reason it's important to bear in mind is that this can be an issue with absorption of your medications like steroids if you give it by mouth. And then the other thing is there is subgroups where there can be very prominent dysphagia, which can cause significant morbidity purely from weight loss. Pulmonary complications is an important part. Certain subgroups will have, and we'll talk about this as we go down this talk. And typically, the pulmonary complications are interstitial inflammation of various degrees of severity, starting from mild down to where it can lead you to have respiratory failure and eventual fibrosis, and also problems with frequent aspiration and aspiration pneumonia-related problems. Joint symptoms are frequent from the arthralgias and sometimes swelling. Nervous system complications are rare, and it can look like overlapping ADEM, and I've seen rarely also as transverse myelitis-like picture. But some of these have been well characterized, and there's really no clear risk that you can ascertain in terms of the antibody profile as to who would have more CNS problems. As we talked about, CK is elevated, 10 times or sometimes much higher. Association of malignancies is mostly a concern in adults. There have been some rare instances in childhood. And calcinosis is where, calcium deposits under the skin. It's a very, very problematic issue of chronic dermatomyositis, and it can be extremely challenging to manage. So the general premise, or most of us kind of hold, is that you try to identify and treat early and appropriately to prevent this problem with calcinosis. Now, this is a picture that, as from Professor Batten. So this I was interested in when I was looking for, what is the chronicity? And here is a child who obviously is showing you profound muscle wasting in the thighs, calves, contractures. And also you could see, this is his biopsy, and you could see a profound perivesicular change where you see, even on this paraffin, significant atrophy, and then with relatively larger fibers, and also thickening of the superficial connective tissue, the epimysium. Now, this was, recognized by Wagner back in 1800, but really, it was only in the 70s and onwards that we are actually, getting a better grip on dermatomyositis. Of course, the prognosis did change when steroids was introduced to treat them. So this is the typical heliotrope on the eyelid. It looks like violaceous. It's the flower. You also get variable amount, and here's the V-shaped sign. This is typically more common with antibody called MI2, but of course it can happen in others. Now, this in the chronic stages, you could also end up with some ulceration and some more aggressive dermatomyositis. So these are extensor knuckle rash and a rash on the shins. And then you would also see variable amounts of changes on the nail bed. Now this can be like hemorrhages. Sometimes with certain subtypes, you could see even bad ulcers. And there is a significant amount of work that has been done on recognizing the number of what's called a capillaroscopy. You could do that using your ophthalmoscope in the bedside, and you could even sort of have a quantitative measurement of how many capillary loops are present on the nail bed, and this can be used also as a measurement of disease activity. So here's a Gottran that's old, and here's a red knuckle with more raised red. And this is calcinosis X-ray, so you could see. Now, calcinosis can occur in places where there's more pressure. Usually it occurs in the arm, also in the buttock and the waist area. It can then start to extrude and become ulcerated and infected, and could be quite a challenging medical problem trying to deal with it. Nowadays, we have moved more into MRI, and the one that's helpful is star imaging. So you can see on your right-hand side, it's a coronal section. You could see right from the pelvis, the gluteal muscle downwards. All of these show, very bright, kind of irregular, stranding kind of appearance. And this is useful in terms of quantitating the amount of disease. And there are many pediatric rheumatology colleagues who would, based on MR imaging with clinical features and laboratory studies, make a diagnosis of dermatomyositis. And there is, in them, there's bigger push towards not requiring a muscle biopsy to come to the diagnosis, unless there were other sort of red flags in terms of rash or other features. The antibodies didn't fit, those kind of things. But so this is a move, and this is also a very helpful technique in terms of monitoring your treatment responses. So if you had a child who was being treated, and if you didn't see the, what were clinical questions, this is a very useful method to quantitate and see. And also, we have tried to study and correlate MRI quantitation, and we did find that it correlates with how the CK and the function generally improve. So it is, quite easily available as a diagnostic tool and a tool for monitoring therapy. So the hallmark of the diagnosis of dermatomyositis is muscle biopsy. And the importance is that this is a patchy disease, as you all know. So it's really important that the sampling is in the right place. So the way we use to identify the appropriate site is based on exam, meaning weak muscle, not terribly weak, but just to moderately weak. And electromyography is also helpful, showing you more changes where it'll be appropriate. And of course, MRI is very, very helpful in showing you where to go to get a sample. So this on the top panel shows you inflammation. This is around perivascular. This is in the perimysium of the muscle. You see a lot of architectural changes. There are internalized nuclei, variation in fiber size. There are some regenerating fibers, some necrotic fibers. And you see that this is more along the edge of the fascicle. This is more noticeable here, that the pathologic changes are more profound on the edge with relatively preserved in the central area. This is a perivascular atrophy with perivascular changes of muscle regeneration and some necrosis. And this one is the alpha stain. This again sort of emphasizes and sort of enhances the change that we talked about of perivascular atrophy. And here you're seeing some, again, some macrophage. And then some, this is the perimysium, which appears to be swollen and thickened. So the characteristic features that will make a diagnosis of dermatomyositis is the presence of perivascular atrophy and inflammation and changes that are perivascular in distribution. And we'll come to this as we go further in this talk. This seems to sort of be the premise that it reflects the vascular etiology or vascular component of injury to the muscle in these patients. If we went further and did some more in terms of the cell markers, you do notice that the cell infiltration is usually CD4 positive cells. And there's also a fair amount of smattering of B cells, which is CD20. The cellular response usually is in the around the vessel and in the perimysium, and it kind of spills into the muscle fascicle. There's really minimal amount of muscle tissue inflammation in the endomysium. B cells are more prominent. T cells, when you do notice, they're predominantly CD4 with a high CD4-8 ratio. Macrophages will be seen in areas. And then you also notice immunofluorescence, which will be towards IgG, towards C3 complement, and against membrane attack complex, thereby telling you that complement has a role and it gets activated as part of this inflammatory disease. Now, the other big thing that has happened in the last 2 to 3 decades or more is really the scope and the value of antibodies in defining these group of diseases. It has actually of late come to a point that it's very helpful. Actually, it kind of gives you some idea about what type of phenotype, what type of prognosis, what you could expect can be determined. And also it has helped with risk stratification in terms of treatment and prognosis. Now this is a little crowded, but this actually gives you the antibody types that are commonly seen in dermatomyositis. I'll discuss this in the next slides, which is MI2, MDAS, NXP, SAE, and TIF. And then also you have this called antisynthetase disease, and then SRP, HMG-CR. Now, all of these are currently easily available here, and I think they're available in many other countries as well. And this has kind of made our ability to diagnose a little more easy, and stratification has improved. So coming to our juvenile dermatomyositis, these are the 5 antibodies that are of interest. The MI2 is really the most common. It's probably about, around 20% of them you may see this. Usually the course is one of a fast onset. Children have typical rash, moderate weakness. It's got good prognosis for recovery. Cancer risk is, absent. It's generally not seen in adults. Now, anti-TIF1 gamma, this is seen both in kids and in adults. It produces more skin redness and more reaction to ultraviolet. It is associated with cancer, so in the adult group, but not so much in the pediatric group. Now, ILD, that is interstitial lung disease, can happen, but not very common. And usually the disease is a little more prolonged. Then you have the NXP2. This is the next most common in children after MI2, large series now with many children where they've studied. And in the adult, there is a, in the kids, the main concern with this particular phenotype is that there is increased risk for calcinosis. And also, so you want to be aware of that, monitoring and looking out for that, much earlier. And it also has a risk for cancer in the adult group. So when you see this in the older patients, especially over 40, it's mandatory that they be screened for cancer with all the standard approach. Now, MDA5 doesn't generally happen in kids. It's associated with a form of dermatomyositis, which is called a myopathic form. That is, you don't see much in the way of weakness, but it's mostly profound skin rash. In these people, they do have also a significant amount of vascular injury. You could see it in skin in the form of large nail fold ulcers. They have patches of alopecia, and then cancer is rare, though interstitial lung disease is a concern in this subgroup. In the SAE group, that also causes a myopathic form and with the rash. And again, it's more common in the Asians. So it's in Japan, and that's where and there is severe dysphagia as a presenting complaint in these patients. I just made a sort of little thing there that amyopathic dermatomyositis, it does occur. It's more often a diagnosis that comes up in adults, not very common in kids. And it's a situation where skin manifestation is present without clinical weakness. So if you did proceed and do some of the imaging and or biopsy, you may see some changes of muscle inflammation. So it is not exclusively, it's more on the clinical basis. The CPK will be normal. And again, there is some issues about how long would you watch. It can be between 3 months, sometimes longer before you ascertain. When you see this pattern in an adult, the concern for interstitial lung disease and cancer is present. So, so these are some of the forms that have. So you have now down from where you could now dermatomyositis into subgroups and ascertain risks in terms of their clinical presentation and give them stratify for treatment. Now, this slide just shows you that, in the inflammatory, especially what we call dermatomyositis plus, it's really a multi-system disease. So you see dermatomyositis with all of those types of antibodies. Now, interstitial lung disease, we'll talk about antisynthetase in a minute. Anti-MDA5, we just covered, is a big issue in that group. The FHL1 and the one with SAE, that there is a concern for dysphagia. And then you also have, we'll talk about skin changes called the mechanic's hand. Myocarditis also does happen, though not very common. It is sometimes seen in the mild with synthetase, and then you could get sometimes in the overlap myositis symptoms of pericarditis, which may be sort of not very profound, but can. The other big subgroup of muscle inflammatory disease is anti-synthetase syndrome. This was recognized in the 90s when the antibody testing became more available and people started recognizing. So this falls into a group of adults, very rare in children. And the typical feature is one what's called a mechanic's hand. So they have thickening of skin with cracking and also sometimes ulceration of the fingers. And it looks like someone who's used their hands to do a lot of, a lot of work. In addition, these people have muscle weakness that can be variable. Serum CPK gets elevated. But the main problem with them is they are high risk for interstitial pneumonitis, interstitial lung disease. That can present as pneumonitis in the very acute phase. That generally is not a good prognostic feature. It can look like presenting with an acute pneumonia, which doesn't get better. It can then, in some chronic, progress further to obliterating bronchiolitis and fibrotic and organizing pneumonia. These things generally end up lung scarring and end up with problems with ventilation and also with elevated pulmonary artery pressures. This is most significant. The most common antibody that's seen associated with that is called anti-Jo1. This can sometimes be seen in even regular dermatomyositis, but this is where it's much more common. And the others that can go along with this are these called PL7, PL12, OJ, and EJ. The difference between these two is Jo1 causes more muscle weakness along with ILD, whereas the others cause more severe lung disease and also very mild muscle symptoms. So it has the other. Now, these are anti-synthetase. These are antibodies that target the tRNA in your body, which is required to form proteins. And it's interesting that it has been noticed that in some of these patients that these things get integrated in different areas, and for a variety of complicated reasons and research that they understand that this becomes the target for the immune attack. Now, interestingly, these patients, cancer risk is very, very low. And treatment for these people will have to be for a protracted period of time. And generally, the prognosis is not the very best for these people. Now, in addition to the Jo patients, Jo1, they do notice that they have increased expression of other pro-inflammatory factors, including ICAM. And then there's also other markers that along with it indicating that you would end up with more protracted inflammatory disease. This is also associated with this HLA marker. But now this particular picture here shows you that here it's got perivesicular change. But what is important here is that you do notice that this perimysium is actually is the target of injury. This is disrupted, it's edematous, and if you stain further, you would see that it's the main cells of inflammatory response along with T cells is a lot of macrophages. One important feature that differentiates the anti-Jo1 muscle from the regular dermatomyositis is what we call as measuring the capillary loop density. I'll show you a picture, but what happens is in the anti-Jo1, the capillary loop density is not reduced as it happens in the dermatomyositis subgroup that we talked about. So jumping a little bit, so people have taken the blood as well as the muscle tissue from patients with dermatomyositis and other inflammatory disease, and I'm focusing mainly on dermatomyositis here. And when you look at their expression profile for a variety of chemokines, you come up with a pattern that shows that the alpha interferons are upregulated and they're overexpressed. And this is based on a variety of one of the markers that's commonly used is this myxovirus resistance protein, which you can stain in muscles and also measure. And it's felt that the source of the upregulated alpha interferons is simply coming from the dendritic cells. These are resting cells in the inflammatory process in the muscle. And they become being inactive to active, which means they become more plump and they can be recognized. And they're also, you could see that they're more active in zones that show more pathology. So these cells have, along with their ability to release interferon, they also help present antigen to the T cells and regulating cells. They stimulate B cell maturation. And the interesting thing is they can be triggered by viral DNA or RNA. So they comes down to the same thing that we talked about, whether a virus of sorts is the trigger that starts this whole inflammatory cascade in these patients. So these are some pictures. So here it's a muscle tissue. The dark pigmented stain is for the mix A we talked about, indicating interferon has been upregulated in these zones. These are like a few samples. And these are the downstream steps, and here's some cells, but again, it just emphasizes the perivesicular zones, the zones that show the pathology in dermatomyositis is where the activity of these interferon-producing cells is also enhanced. And this particular slide again shows you this is an inactive dendritic cell. This is a activated plump plasmacytoid cells. Now, along with that, the other things that play a role is the MHC complex. This is involved again in activating the immune system. These cells will have MHC complex, this again, MHC is noticed more along the edge. Now, this is felt that this then leads to a microvascular injury. So the two slides here, it shows you these have been stained with lectin. So this is a more normal where you see capillary density. And here there is a dropout in the perivesicular zone. So this is a characteristic feature also seen in the JDM and the regular adult. And it's felt that this capillary dropout is as a consequence of vascular injury, and the vascular injury is triggered by the complement system along with others. And it's felt that perhaps the interferon brings about all this. So once you have a depletion of capillaries, you are reducing a ischemic state, and the muscle fibers are thought to undergo shrink in size or die, and then show, of course, regeneration. So to kind of put it, so viral DNA and RNA, it's thought to sort of activate dendritic cells, make them active, then that then releases interferon alpha to pathways, complement activation occurs. There's endothelial injury, and then perivascular injury, and then the consequence of muscle damage. Now, there are studies that have shown that there are circulating endothelial cells. If you look at patients with dermatomyositis, they have an increased number compared to other inflammatory disease when you look at their bloodstream. Also, fragments that indicate endothelial injury that are increased, indicating that there is vascular injury in this subgroup. So, amyopathic dermatomyositis polymitis, as we said, again, it's muscle involvement without muscle weakness. ILD is frequent, and it typically, the duration of observation is kind of nuts, but it's probably 3 months, but some people have gone further. Therapeutic implication is present in choosing immunosuppressive treatment. At this point in time, now at least we have the antibodies against MDA5 and SAE that'll tell you that these people are at high risk, and you could perhaps be more aggressive based on that. Okay, now coming down to polymyositis, it's a very uncommon diagnosis in childhood. And you have to be very, very, very careful when somebody comes down with a diagnosis of polymyositis, especially in kids. Even in adults, it's a rare diagnosis. It's often other things like IBM or other viral or overlap myositis that possibly, or it's a genetic muscle disease. Just to the interest, this is a paper from 2003. Here, they looked at 165 patients who were 21 years. They didn't include clinical IBM. And then when they look at it, true polymyositis was just 5% of the 165, which means they didn't find a reason at that point in time. So in majority of them, it could be something else. So we have to be really careful when we make this diagnosis. At this point in time, quite often we may, at least in the pediatric subgroup, we may be calling some of the genetic muscle disease as polymyositis. The most common or important ones that come under this to be considered are on your left panel is a patient who has polymyositis picture. You see, there's invasion of a intact muscle fiber and inflammatory cells in the endomysium. The other disease that can look like this, you can see this with facioscapulohumeral dystrophy, quite profound. You also see this in Duchenne dystrophy in pockets. You see it in dysferlin disease. Laminopathies in childhood will have a lot of inflammatory change. It's also present in some of the toxic muscle disorders and in myasthenia gravis. And we also have to, in these days, keep in mind that it may be related to some of the viral syndromes like COVID or West Nile virus that can also look like this. So while it happens, it is quite uncommon. And when polymyositis does happen, you often end up also noticing that there are other clues, like there may be antibodies against the muscle-specific antigens, like, telling you that this is a, overlap or combined, or this is really, it's an immune disease. Now, the other big area that's of interest these days is the immune-mediated necrotizing myopathies. Not common, and again, not very uncommon in childhood. The reason I'm bringing it up is because it's important that sometimes these children can present to us and they can look like difficult patients with limb-girdle disease. And when you have a situation where it looks like limb-girdle disease, but you're not able to find a specific genetic reason, don't dismiss this. This can be also looked at. So that in the adult group, it's a little more common. It's usually older people, and it has, again, a subacute onset and progression, involves proximal muscle groups. Now, SRP muscle disease typically will also affect your neck extensor, so they have more neck weakness. But, and then HMGCR, there may be history of statin exposure, but that's not required to make the diagnosis of HMGCR myopathy. There are patients in the pediatric age group who have HMGCR myopathy. And the way we kind of think about this is perhaps, it may be through We do eat, mushrooms. Some of the mushrooms do have statin-like compounds, so it can be involved. So the anti-HMG-CR, it's kind of more, it's again, symmetric progressive weakness. One of the things here is it's a necrotizing disease, so your CPK will be quite high, tens of thousands and 20,000s. Variable amount of muscle pain, no skin rash, joint or pulmonary involvement, irritable myopathy on EMG. Biopsy will show prominent muscle fiber necrosis and regeneration with minimal lymphocytic infiltration. Muscle weakness will also show, a lot of changes, and typically it prefers the hamstring and gluteal muscles more than the quadriceps. You do recognize that you could measure the anti-MGS antibody or SRP. They could look very similar in many ways. And then this can be also used to monitor your treatment. Say, for instance, you have a HMG-CR patient, you treat them, you could use their titers as a means to tell you how you're responding, along with other markers, of course, clinically. And people with HMG-CR muscle disease in the adult group can have cancer. It's higher than normal population. And the other thing to remember is that when HMG-CR presents as a long-standing disease, it can very much simulate limb-girdle muscle disease. There have been instances of pediatric patients who have labeled as LGMD and then diagnosed later with this, because then this is treatable and it responds well to steroids and also very well to intravenous immune globulin. On the other hand, SRP is similar and aggressive, and it's much more harder to treat. So this is a paper from Andrew Mammon and his group. So it kind of summarizes. So here you see this is the T1, this is a stir image. Here there is a lot of muscle atrophy. So the gluteal muscle barely shows some brightness. Here again, you see in the quadriceps. And then when you do a biopsy, there is necrosis and inflammation and fatty replacement, and also some endomysial fibrosis. So this can very well be mistaken in the pathology setting to be any kind of limb-girdle dystrophy based on just these features, and it can be challenging to sort it out, especially when history doesn't fit or if you don't have the antibodies. The other one is SRP, which looks very much like it, except that it involves the neck muscles. And interestingly, I have this picture. What is SRP? SRP is a protein that's needed to shunt the proteins that are made in the cytoplasm into the endoplasmic reticulum. And for some reason, this becomes the target for injury in these patients. These patients are more difficult, but they do respond to rituximab. Now, in terms of treatment, there have been several trials that have been done. I'm not going to go into, but just summarize. And so the anchor for treatment is glucocorticosteroids, at least in children. We go with dose of steroids of 1 to 2 milligrams per kilogram to start with. This is usually not very severe type of patient. Also, IV sodium withdrawal can be used to sort of for a few days to induce this, so to speak, so you kind of get a burst. And then in some, we have done where patients have remained on pulse steroid for a long time. You may want to sort of think about this when GI inflammation is a big issue. You may want to sort of, be sure that your medication is being absorbed. The way you do it is you get, some clinical and improvements, or remission, and then start a slow tapering dose following that. In children, we always use methotrexate. It's usually 15 milligram per meter square, given subcutaneous weekly. There are other regimens, but that's what is followed. In more severe disease, IV solumedrol is preferred. Usually you give them a bolus for 5 days, and then sometimes we may continue this weekly for 12 weeks and then change over to oral prednisone. It's a kind of a patient-to-patient kind of decision. But overall, if you look at it, everybody kind of comes to the agreement that steroids given appropriately is helpful and it's important. Now, we talked about methotrexate. IVIG is useful in severe disease and it's quite effective. It's a standard dose of 2 grams per kilogram, followed by weekly or 3 to 4 weekly infusions, depending on what you want to do. And it's very helpful in patients who have a lot of skin issues, and also in the subgroups that we kind of talked about. Rituximab has been used and it's quite helpful, and it improves your chances for a remission. The other things that I've tried in small groups and usually not large patient groups is Celcept, tacrolimus, cyclosporin, azathioprine. But of late, we're also looking at, based on the understanding of the pathogenetic mechanisms, complement 5 inhibition therapy with eculizumab and zilucoplan has been tried in some resistant and difficult patients. We also have Janus kinase inhibitors, B-cell activating factor inhibition, interferon alpha inhibitor, interleukin-6 inhibitor. We would like to sort of wait and see, how this sort of pans out, in the sense, when we get more information, we may kind of come to a point that these may be more appropriate in these subgroups based on their biology and pathogenesis. Screening for occult malignancies. Occult malignancies are rare. There have been instances of lymphoma and leukemias. There have been some studies with 60 to 80 patients where they noticed an occasional one, but it's not generally, even with the antibodies that have high predilection in the adult group. In patients who are over the age of 40, there's about 15 to 20% risk of cancer overall. So the antibodies to NXP1, TIF-gamma, HMG-CR, and negative forms of immune-mediated necrotizing myopathy are high risk for cancer. Cancer screenings are standard. It's usually CT scans or PET scan, depending on what your institution would allow, and it's generally done once and then repeated up to 3 years if the risk is high. And if they are low risk, probably some would even settle down with one screening initially and then close monitoring. Coming last to prognosis, like everything else, this dermatomyositis, especially in childhood, has a pattern of 30-30-30. So it's like 30% would have a monocyclic course. That means one time you treat them through that, usually about 2 to 3 years, and then they have achieve remission. 30% would be having a more chronic indolent course, and 30 would have multicyclic. That means every attempt when you try to taper or bring down, they have a relapse. As we talked about, mortality is still there. It's about 2 to 4%. Remission-free from medication would be about 40 to 50%, usually 2 to 3 years. In adults, the mortality is higher when there is interstitial lung disease and cancer. It can be quite significant when they have severe ILD, like the pneumonia form. You could have about 20-25% mortality in the acute rapid. We have noticed that multidisciplinary care with the multiple specialists, neuromuscular neurologists, rheumatologists, internists, actually improves the clinical outcome because you have to be more multimodality driven along with therapy, nutrition. Now in children, there are the two which are of great concern on the long term is calcinosis and lipodystrophy, which is a syndrome where you lose subcutaneous fat in the limbs, but accumulated in your trunk. And they may look like they're, strong, but, abnormal muscles. And, but they also have a serious, severe metabolic syndrome, which makes their general management difficult. Finally, the messages, inflammatory muscle disease is severe, but still progressive disease, which is treatable, and it's rare. Clinical features can mimic at times inherited progressive myopathies. Understanding the pathology has helped us through studying serology, muscle pathology, and we also have to be cognizant that there's extramuscular involvement, and they need to be part of the screening process and monitoring. Steroids are still the anchor, though we use others for steroid sparing and to improve the remission rate. Mortality and morbidity has improved, especially in the childhood, but much needs to be learned about the biology of this disease. So thank you very much for this wonderful opportunity. I'm sure I'm ready for some comments or questions. Thank you.
Thank you, sir, for your lucid talk. I think it was very comprehensive and very has covered almost all aspects of the inflammatory myopathies. We'll take some of the expert comments, ma'am, here.
Yes, Professor Olu.
First of all, I want to thank you very much for your kind invitation, and this was an excellent talk, Dr. Veda. Thank you very much for your lecture on inflammatory myopathies. So in our country, Turkey, we have also opportunity to look for antibodies in childhood inflammatory myopathies, and this makes the work easier because when you have a specific antibody, you can comment on the prognosis, and as you comment, most of these inflammatory myopathies are treatable. Although it's hard to treat, but they are treatable. And we have lots of new medications like Janus kinase inhibitors, although they have not been approved by FDA yet. But there are very wonderful reports on adult cases and child cases who were treated with Janus kinase inhibitors. And they are free of disease without using any steroids or methotrexate. And so, thank you.
Thank you. Yeah, I agree. Our group here also is, using them, and I think, those are some of the things that need to be looked at in terms of whether you could treat them, ab initio without steroids, right from get-go, and not have to put them on long-term steroids.
Yes, long-term steroids are also very important from my experience, and I think rituximab is not working so much on cases of dermatomyositis. So what's your experience with rituximab?
We haven't used many, but we have a few that have been resistant to IV steroids, or where we have to sort of what we call is keep them on a maintenance, and it has helped to bring down, and so we don't have large group of patients on that. So we are mostly sort of still focusing on some of the, like you said, the Janus inhibitors, and our rheumatologists are sort of more in that direction.
Thanks.
The Sharma.
Oh, thank you.
Neuropathologist.
Excellent lecture. Can you explain a little bit about the FHL1 and myasthenia, the differential?
I'm sorry, can you repeat your question for me, please?
FHL1 and myasthenia as a differential you said for the inflammatory myopathy.
Well, this is mainly in the patients who develop inflammatory myopathy in the setting of the checkpoint inhibitors. And then it's probably a combination of both. So they do develop symptoms of myasthenia and also have myositis, both sort of go along with it. If you look at the literature, there's some German, there's also where you have myositis with myasthenia after bone marrow transplant. And there are also some rare instances where similar picture would occur rarely with aggressive thymomas, where you get a myositis and myasthenia.
Thank you. In one case, I found some internuclear inclusion in the alpha antisynthesis, which is described by the French in many cases. But after that, I did a lot of ultrastructural examination of muscle biopsy, but I couldn't find any case, only one case.
I mean, the internuclear inclusions, I think they made a big issue. I mean, you're talking about internuclear inclusions in the endothelium?
Yes, yes.
Okay. I mean, that is sort of, they were taking it as a marker for some vascular injury or a viral injury. I mean, they still kind of use that for dermatomyositis as a marker. But in our practice, I do, read the biopsy, but usually we don't do, electron microscopy in these. We kind of settle more and then sort of more focus on immunocytochemistry to understand. But you're right. I mean, some of them are supposed to have vesicular and tubular inclusions, and they're thought to indicate, some vascular changes.
Thank you, sir.
Professor Rohit.
Oh, thank you. Thank you, Dr. Veda, for the detailed lecture on inflammatory myopathies. I'm an adult neurologist, but we do see adolescent children, and we also see adults, of course, frequently in our center with inflammatory myopathies. My only comment is that although we have kind of grown a lot in the myositis specific antibodies, and I think of recently, including in the pathology, there has been a lot of interest in the interferon pathway and recognizing the interferon pathway, especially in the dermatomyositis, which is MDA5 related. But I think our treatment paradigms have remained more or less pretty generalizable. So pragmatically, and for if we want to set up guidelines for a more generalizable approach to inflammatory myopathies, I don't know whether we can justify a pan knowledge about using antibodies in all patients, or we should be more specific when we are using a clinical and a phenotypic organization skill and clinical phenotypic organizational methods to place them in a category. So that is something I would want your opinion as well, whether that is something which is generalizable. The other thing is that the use of second line agents, I think pretty much as you said, we all use steroids generally as an induction using methylprednisolone. Then we start oral and we quickly build on, using immunosuppressive therapy. But there is generally a rheumatologist generally tell us to prefer methotrexate. We are more comfortable with azathioprine. So this is always a kind of a dialogue that we look into, and I think it comes from more evidence from rheumatology. But beyond that, if someone is not responding, I do not know what's the current, how do you currently place using IVIG? Because in some patients, IVIG may be beneficial, especially in the necrotizing myopathy group to some extent. So that's where I think a pathology descriptions really help us, especially the true immunostains and the type of T cells and the kind of the behavior we see on the pathology to direct treatment. And then the choice between using cyclophosphamide for very bad myopathies who are not responding versus transitioning quickly to rituximab. And you would agree that some of these new agents, the TNF blockers have not shown very promising results in the randomized control trials. So these are kind of my observations, and I think we need to make sometimes individualized decisions, but the generalizability still remains in most of the treatments.
Sure. I mean, you are very succinct, and you kind of summarized, all the issues and challenges and roadblocks. So I agree with all of your observation. The way we at least do is when I see some adults too. So when I see them and they have a clinical picture consistent with inflammatory muscle disease, we get the antibody test. It's easy. It's not very expensive. The only trouble sometimes it takes time to, especially if you're sick in the hospital, you have to wait weeks to get the answer on that. So you make a clinical, and we would proceed with imaging. And also with a biopsy. A quick look at the initial biopsy would tell you, what you're dealing with, whether there's profound inflammation, and getting an immunocytochemistry usually it's less than a few days. And then, so my approach is if the patient is stable, comes to the clinic, we would take a more slower approach, whereas those who are in the hospital, more acute, it'll be a biopsy as the first step, followed after imaging would be the next step, and then followed by, of course, the antibody testing, because you really want to start some treatment if you see convincing evidence for major inflammatory change while you're waiting. And then I think the antibodies are very helpful in, eventually deciding how to approach, what to do with these patients, because clearly you could stratify patients based on the antibody profile. If you had, I'm just saying the pediatric, if it is MI2, antibody positive subtype, in all likelihood, it's going to be generally not very aggressive disease. Versus if you had JO1 or you had the anti-synthetase, I mean, that's always, you want to up your game quickly. And, so in terms of the IVIG, I mean, resistant dermatomyositis followed by necrotizing myositis, primary will be the ones. But I generally would avoid an anti-synthetase, things like methotrexate, because you don't want to add to the pulmonary, complication from methotrexate. I'd rather choose, CellCept. The only thing with Imuran is that the onset of the beneficial response, it takes a while to, but maybe CellCept is a good choice, and they keep moving. People talk about CellCept as a good option in those settings. And then, of course, finally, as you mentioned, the TNF, alpha, they have not been very successful. Actually, there have been some instances where it has triggered myositis. It just brought it out. And similarly, they now had some of the others, septs, one of those that work on the soluble T cell CD4 with which abatacept. It's supposed to sort of help a small group of patients with calcinosis. But in my experience, if you treat them, the three anchors, which is steroids with IVIG, with methotrexate and or others, you're most often able to sail through majority of the instances. But I think it'll be interesting to see further, like recognizing whether we can treat it differently if you stratify them in different groups. And our approach is to really quickly try to divide them into which group they fall. I mean, I heard of a recent patient from one of my colleagues, not here, friends, a teenager who for many years got a label for, limb girdle dystrophy, not defined because the genetic testing didn't pan out. And then it turned out to be, HMG-CR myopathy. And similarly, I've heard where SRP myopathy we had one child with SRP myopathy. So it's not like it doesn't happen, it does. So screening them in a broad way still makes sense.
Thank you, sir. Thank you for your insight. We'll proceed to the case discussions directly because there is a lack of time. So I request Professor Uluk to present first the case. Would I request them to keep it concise and short? Thank you.
Okay, can you see my slides?
Yes, sir, we can say.
Okay. So my case is, it was 20 years ago, and I was a pediatric resident, and I was working in the pediatric emergency department. And I saw an 8-year-old boy who presented with one history of high-grade fever, abdominal pain, facial edema, and myalgia for 1 week. And he could not climb stairs or rise from the floor without support. And he was previously healthy, no chronic disease, and he had a normal mental and motor development. Interestingly, parents all had also had the same symptoms like this child. The physical examination revealed a high fever, and he had generalized proximal muscle weakness, and the Gower sign was positive. And he had a generalized decreased deep tendon reflexes, and there was a severe muscle tenderness, generalized muscle tenderness on palpation of the muscles. And he also had facial and eyelid edema, and the conjunctiva was apparent as shown in the photograph. When we look at the laboratory examinations, there was leukocytosis with marked eosinophilia, and his serum creatine kinase value was also raised, and he also had increased C-reactive protein. And an EMG revealed normal conduction velocities, but there was myogenic potentials with sharp base and fibrillation potentials. So, and this was the needle examination from the biceps muscle. He had normal motor unit potentials. With the contraction of the biceps muscle, now you will see early recruitment with, yes, small polypositive sharp base showing myopathy. So during the following 2 weeks, we saw about 50 children who presented with the same symptoms and about 100 adults from the same neighborhood, and all had a history of consumption of a traditional food called çiğ köfte in Turkish. It's a kind of meatballs made from uncooked veal, wheat, tomato paste, and hot spices, all from the same restaurant. And the common problems for these children, all of them were previously healthy, and they had high-grade fever with muscle tenderness and abdominal pain, increased muscle enzymes, and all had myopathic EMG, leukocytosis with eosinophilia, and they had a history of consumption of same food from the same restaurant. And this raises the suspicion of an inflammatory, especially infectious myopathy. So the examination of the meatballs from this restaurant showed pork meat was mixed with beef meat, and the muscle biopsy examination of the patient showed Trichinella larva is shown in the figure, and the further examination of nematode larva from the meatballs and muscle biopsy examination showed Trichinella biritovi. So mebendazole was started in a daily dosage of 25 mg/kg per body weight, divided into 3 doses for 14 days, and was prescribed to all children. And the patients who had severe myalgia and periorbital edema and fever were also treated with prednisolone for 1 week. And the average symptom resolution was 8 days after the beginning of treatment, but the myalgia persisted for 2 weeks, and in one child it persisted for 40 days. And serum muscle enzymes and eosinophil count dropped to normal level by after 5 weeks of treatment. And no child had neurological cardiac complications, and no children also had an increase in serum electrolytes or hypoalbuminemia. So the case was trichinosis. So it's an infectious myopathy, and it's a zoonotic parasitic disease, and it shows worldwide distribution. And it results from the consumption of wild animals like horse or wild boars. But the most common problem is the free-ranging pigs from organic farms. And in Turkey, regarding Turkey, which is a largely Muslim country in Europe, consumption of pork is quite unusual. And the trichinosis is extremely rare in our country, strictly prohibited by religion. And we have two species like Trichinella spiralis and Biritovi. And Biritovi females produce fewer number of larvae, so the severity of infection is less in Trichinella biritovi. And the main clinical symptoms are related to the infecting dose and possibly an allergic reaction to parasite antigens. So the human beings, first of all, eat the infected meat, then the larvae penetrate the epithelium lining of small intestine, and they become sexual mature adults. Then the newborn larvae enter circulatory system and migrate to muscle disease, and after that, the symptoms of the cases start. All of the patients had high-grade fevers, headache, and myalgia, and most of them also have a periorbital edema mimicking dermatomyositis. And several cases might have complications like carditis, respiratory failure, and sometimes central nervous system problems like seizures, meningoencephalitis, and in several cases, cerebral edema and herniation. So the detection of specific antibodies has a great diagnostic values, but the titers rise during the following 3 to 2 weeks. So at presentation, muscle biopsy is the diagnostic procedure of choice, and we have to treat these patients emergently because if the larvae make a collagen capsule in the muscle, it's very hard for mebendazole and albendazole to penetrate this capsule, and it may be very hard to treat these cases. So this was the first outbreak in Turkey, and the first cause of infection of this outbreak was failure of inspection. And the second cause was the use of pork instead of beef meat for its lower price. And after that, new regulations included the sale of prepared fresh meat is not allowed without certification and inspection by the Ministry of Agriculture and Rural Affairs. And thank you very much for your attention.
Thank you, Professor Yuluk, for this absolutely amazing case. I think we rarely encounter such cases in India. Among parasitic infection, I think one disseminated neurocysticercosis is one which we do see in India, where there's a large amount of parasites are infiltrating the muscles, but they usually do lack the kind of allergic reaction in terms of rash and edema. So I think this was a wonderful case, and we have learned a new entity from you with the clinical presentation of that. Thank you so much.
A couple of years back in Uttarakhand, there was similar incidents where the wild boar was eaten by the whole of the villages, and I think more than 10 or 15 people died because of myocarditis. One of them came to AIMS and they did the biopsy. It was Trichinella pituitarius. I think it's the myocarditis which is the cause of death.
Thank you, sir. Any other comments regarding the case, Professor Rohit?
Professor Veda.
Professor Veda.
Fascinating case. But,
Thank you.
I mean, I mean, maybe that's why you remember it from your residency.
Right.
It was 20 years ago. Yeah.
True.
Yeah.
We'll proceed to the next case. Next case is being presented by Dr. Shagun. Dr. Shagun is a DM Pediatric Neurology Fellow at PGI, and she will present a case of inflammatory myopathy in a young child. Dr. Shagun, keep it short and so that we can have few questions after.
Yes. So are my slides visible, ma'am?
Yes, they are visible.
Good evening, everyone. I'll be presenting the second case for today. So we have Miss S, who is currently 7 years old, and she presented to us first at the age of 5 years in November 2022. Her chief complaints were that she had frequent falls while walking for around 2 months, and for the last 15 days, she was not able to lift both her arms. So it started as a difficulty in climbing the stairs, more upwards than downwards. And 1 week into the illness, she was unable to stand from the sitting position and she had frequent falls while walking. She could remain ambulatory independently, but would often waddle from side to side. Over the next 2 weeks, she could not get up from the bed and would require the support of her arms while turning from side to side, and would lift her neck off and was not able to lift her neck off the bed without support, and she could no longer sit cross-legged and required support to rise from the chair. Subsequently, she was also unable to lift both her arms overhead. However, there was no difficulty in eating or there was no change in handwriting. There was no history of any drooping of eyelids or limitation of eye movements or double vision. There was no history of difficulty in drinking from a straw. No history in chewing, eating, or did not complain any difficulty in swallowing, and no history of change in voice. There's no history of slippage of any slippers, no diurnal variation or easy fatigability was noted. There were no sleep disturbances, no headaches, or no difficulty in breathing. There was no history suggestive of any other part of the neuroaxis involvement. There was no history of any rash around the eyes, no facial rash, no joint pain or swellings, no oral ulcers, no alopecia or bleeding manifestations. There was no history suggestive of a viral prodrome, any recent vaccination, or any drug intake prior to the onset of illness. Her antenatal and birth history, as well as the developmental history, was unremarkable. The family history was normal. There was no history suggestive of myotonia or weakness in the mother, no history of cataract or thyroid or diabetes in the mother. So we have a 7-year-old girl who had a subacute onset of weakness with proximal weakness, lower limbs being affected more than the upper limbs, with neck flexor as well as truncal weakness, with no evidence of facial, bulbar or ocular weakness, and no fluctuation or fatigability. So coming to the examination, her vitals were stable, her anthropometry was preserved, general physical examination was unremarkable, there was no rash around the eyes, back or neck, no nodules noted on the hand, no fasciculations, no hypertrophy, and no palpable nerves. Coming to the neurological examination, the higher mental functions and the cranial nerve examination was normal. In the motor system examination, she had a waddling gait. The bulk was normal, the tone was normal, the reflexes were normally elicitable, and the superficial reflexes were normal. As far as the muscle power was concerned, so she had a distribution of weakness in the limb girdle pattern as well as the neck flexors. So other systemic examination was normal. So we just add that reflexes were preserved to the historical database. So she again had a proximal weakness in the limb girdle pattern and preserved reflexes with no facial, bulbar or ocular weakness. So coming to the localization in this case, so our first localization and possibility was a muscle disease. Points in favor being the proximal dominant weakness with reserved reflexes. So the disorders we had considered were an inflammatory myopathy, a JDM or a juvenile polymyositis, a metabolic myopathy like the late onset Pompe or FAOD. However, there were no previous episodes. Endocrine or toxic myopathy, there was no history suggestive of the same, or a muscular dystrophy. However, the progression of this illness was very rapid. There were no contractures and there was no atrophy or any hypertrophy of any muscle groups that was noted. The other possibility that we had considered was neuromuscular junction disorder. However, there was no fatigability, no involvement of the ocular or faciobulbar musculature. And the preservation of reflexes and the proximal dominant weakness was against the possibility of nerve involvement. Coming to the investigations, so at the onset of illness, when she had presented to us, the muscle enzymes were elevated. The CKNAC was 30,000. Liver enzymes were also elevated. The rest of the endocrine workup and the inflammatory workup amongst the antibodies were negative. In the myositis antibody panel, the myositis specific antibodies were negative. However, among the myositis associated antibodies, anti-Rho antibody was positive. The ECG and echo were normal. The nail fold capillary scopy was also normal. The NCS and RNST were also normal for. So we proceeded with the muscle MRI, keeping in view of the possibility of inflammatory myositis. So it showed a subtle hyperintensity in the bilateral vasta lateralis and the left rectus femoris, as well as the adductor group of muscles. So the features were suggestive of myositis. And a muscle biopsy was also done from the vastus lateralis. However, it was non-specific. It did not show any necrosis. It did not show any perivascular inflammation. No endomysial or perimysial infiltrate was noticed. There were a few CD3 positive T lymphocytes. So it was not fitting either into a JDM or a JPM phenotype. We also did a FDG uptake, which also showed increased uptake in the muscles, mainly trapezius, the adductor group of muscles in the hip and the thigh, and the rectus spinae muscles. So again, features suggestive of myositis. With the possibility of inflammatory myositis only, we managed the child. We monitored on the basis of CMAS scoring, which is the composite muscle activity score, as well as the CK levels. So when she had presented to her score was 15/51, which falls into the moderate category of weakness. We had started her on steroids, pulse steroids given at 30 mg per kg, and started in November. And because of the persistent weakness, it was again repeated in 1 month later. And she was also given IVIG on 2 occasions, 1 month apart. She was simultaneously started on methotrexate, 15 mg per meter square weekly doses. So as the course progressed, now she's 1.5 years into the illness, and she has improved significantly. The CMAS score is now 44, and the CK levels have dropped to 551. And clinically, the weakness, she herself tells that there is around more than 90% weakness, resolution of symptoms. So this is her current video. So she can run, she can get up easily from the squatting position, and she can comfortably jump as well. Coming to the discussion, Sir has already elaborated. So earlier we had the Peter and the Bohan criteria for JDM. Now we have the more extensive Euler classification, which is based on age of onset, muscle weakness, and the skin manifestations, as well as the muscle enzymes. So on the basis of this, the classification is probable, definite, or the possible inflammatory myopathy. So patients who meet the Euler classification are further subdivided into the type of inflammatory myopathy. So if they have a characteristic rash and the weakness is in the suspected areas, and the treatment response is there, so it is the juvenile dermatomyositis. And if the weakness is, if there is no rash, but the weakness is present in the muscle groups, and the treatment response is not so great, and the rimmed vacuoles are there in biopsy, so it becomes a part of the inclusion body myositis. So another treatment approach which was found in our particular patient, we had a symmetrical proximal muscle weakness, but we did not have any cutaneous findings.
Shagun, I'll have to ask you to stop, Doctor, for a minute. I mean, you can give your concluding slide after 1 minute. Dr. Veda has to leave. So can you just stop sharing your screen for the moment? Then we don't need this, the literature part thing that's already been covered. No? So just take home message later on, Renu will give for the case. Dr. Veda, but I would request you to give them take home message. And before that, Renu, can you just pick up any questions which is there, something generically, if something has to be asked from Dr. Veda? Dr. Veda just talked about seropositivity, whether it influences treatment choices, role of HSCT in inflammatory myopathies, and regarding avoid of methotrexate. These are something besides a take-home message from your side before you log off, sir. Thank you. And we'll anyway wind up in 5 minutes the entire session. It should have finished at 9:30. Yeah. Dr. Veda?
Sir, you are mute.
Okay, sorry. In terms of the methotrexate, I would generally avoid if there is concerns for interstitial lung disease, because that'll kind of add to the problem. But in that situation, I would use mycophenolate. You know, as I said, you know, it takes too long for Imuran to kick in. So for that. I'm sorry, what was the next question?
Whether antibodies have any role, whether the seropositivity has any particular influence on treatment choices, and you have an algorithm.
No, I generally, you know, for instance, if I do see the anti-synthetase antibodies are positive in an older person, I know that it's going to be a long haul. It's going to be a longer treatment. Perhaps, you know, this would be the one where we may consider adding maybe 2 immunosuppressant, maybe with Imuran, sometimes with Celsa in that circumstance. Or if you had a kid, for instance, or if you had, for instance, if you had a necrotizing myopathy with the HMG-CR, there are some who even go to the point of saying just treat them with isolated IVIG alone. I mean, but it's still sort of, and then of course we just briefly touched upon that we are looking at medicines that can work directly on the interferon pathways, the biologics, but you know, we still need more experience on that. And lastly, of course, if it is SRP myopathy, I would go to choosing Rituxan quite early in those patients because they're difficult and they do respond to the. But for the most, you know, the other types, it's, you know, like the MDA5 and the TIF gamma R, they're just going to sort of act out the way, so you would approach them as the others. And then if they are difficult, then you'll escalate your treatment.
HSCT, any role in case of resistance? That was another question.
I'm sorry, what is HSCT?
Hematopoietic stem cell.
Oh, I have no experience there with that. Yeah, no.
And any comment you have on?
No transplants? No, I have not seen anybody sort of take that approach of, you know, myoblast transplant.
Any comment for the PGI case?
Well, that's interesting. So this is an overlap type of myos. It looks like has features for, you know, Sjogren type of, and has inflammation on top of that. So it's going to behave more or less like dermatomyositis, which is what you're saying. And so this child is now on steroids and methotrexate.
Yes. Yes.
Okay.
In remission at present, and
so
enzymes are also.
I'll take them off the steroids and then later methotrexate, and then sort of see what happens. You know, we have the 30-30-30 rule. You don't know, you know, who's going to relapse. That's a concern.
Thank you. And your take-home message for everyone.
Oh, well, you guys know a lot, I think. I mean, it should be considered in the differential, and I think we should be, you know, engaged more in treating these kids, I think, with the rheumatologist. And I think we should go more towards multidisciplinary approach where, you know, it's not just them, not us, but it's probably combined. It seems to be better.
Thank you so much, Dr. Veda. Have a great day. Thank you very much. Yeah, thank you. Renu, to just conclude, can you give the, thank you. Renu, can you give your conclusion about your case? Then we'll have Professor Aluk, Dr. Sharma and Dr. Bhatia to give their comments and take home messages.
So absolutely, there was absolutely absence of any kind of skin manifestations in this girl when she presented. There was no myalgia as such, and the nail fold capillary pattern was also like negative. So diagnosis, and it was a kind of subacute and rapidly progressing disease with elevated enzymes were like significantly elevated. So in such situation, usually the confusion arises between a JDM without rash kind of presentation versus overlap or a polymyositis kind of a condition. So so fortunately, this girl responded beautifully to the immunomodulation, and she has a quite uncomplicated course with the kind of improvement gradually over the time. So biopsy was also not like really characteristic of specifically JDM or polymyositis. So it remains possibly unclassified, or as Sir has suggested, an overlap myositis, though there are still no other involvement in terms of arthritis or other kind of other autoimmune disorder. So, so one question in such cases comes like, do you still think about alternate diagnosis in situation like IMs, which can present with this kind of fluctuating course, and is it all this criteria and response to therapy is very certain that we are dealing with the polymyositis or this unclassified inflammatory myositis in such cases? So I'll take comment from Professor Ullik and Professor MC Sharma and Rohit Bhatia, sir.
Thanks, Renu. I will request all Professor Aluk followed by Professor Sharma and Professor Rohit to give their the comments on this case plus the take-home messages for the entire session. Yeah. And I really want to say, Professor Aluk, thank you so much for sharing the case, very interesting case from your residency time. I mean, it's really nice. It's stuck with you, very interesting one. And Dr. Sharma supplementing with what he saw here. So Professor Aluk, please.
So the thing I want to say is that we know that dermatomyositis are the most frequent inflammatory myopathy during childhood, but in our region, in Turkey, in India, in Middle East, we have to keep in mind the infectious causes of myositis, like trichinosis, tuberculosis, HIV, brucellosis, because like inflammatory myopathies, they are also treatable, and also tuberculosis. And as far as I know, the consanguinity rates are also high in India, like in Turkey. And Renu, as mentioned before, we also have to keep in mind the inborn errors of metabolism. And they can also present with fluctuating weakness, like urticaria type 2 or other mitochondrial disorders. So we have to keep in mind the infectious causes and metabolic myopathies in this part of the world. Thank you very much.
Thank
you.
Nothing specific, but can you tell me anyone who was in the youngest patient of an inclusion body myositis? Is it always after the age of 50 or also in children? I think Dr. Beda was the best person to tell.
Right.
Any take-home messages from your side?
Actually, what we know, we would always try to fit in three, four categories whenever we get the muscle biopsy. For example, after the COVID, there are many cases which are be diagnosed as dermatomyositis. But I don't know, maybe the infectious causes or viral after some time. They're not immediately, but thereafter 6 months, 1 year, there was history of COVID in those patients. I'm not very sure. We are always trying to fit one or two, three categories. We have seen some sarcocystal Lindemani, which is, I don't know, but biopsy was done in an adult, but for some other muscle weakness, it turned out to be some parasitic infection, which may be, I mean, incidental, or I'm not very sure. 2, 3 cases we have seen over the time.
Thank you, sir.
Thank you, sir.
Professor Rohit, your
So-
take-home messages and your comments on the.
A few points, especially for trainees and residents. First, take your history very well and clear on your time points of onset and progression. That's very important when we are differentiating heredofamilial diseases with acquired, especially. Try to look for fluctuations, any other, inputs suggesting any metabolic defects, which could also sometimes be confusing in patients where we are trying to diagnose them inflammatory just on the time course. Number 3 is that always characterize your patients well clinically and note down all the areas of involvement, because it helps a clinician to really judge whether the patient is improving. It's not always necessary that the improvement will be in the same time course as you expect, but there will be other improvements systemically which will guide you that the patient is improving as well. Fourth is that presence of antibodies now probably have helped us in better characterization and prognostication, and especially where your pathologist is labeling immune-mediated necrotizing myopathy, HMG reductase in antibodies are helpful and sometimes important to differentiate or prognosticate patients in such kind of scenarios. Fifth is about the treatment paradigms. I think we've all discussed them and we should go step by step. Sometimes we may have to combine treatments early on, for example, steroids, followed by IVIG in some patients, and especially in some specific antibody-mediated disorders. And then, of course, move to the long-term treatment plans, sometimes using more than one treatments as well. And of course, a good follow-up and characterizing improvements in all domains is important in these disorders. There are no right fits and right answers. And many times, as was presented by the colleague Shagun from PGI, the biopsies may not be, showing elaborate findings, but a clinical suspicion and therapeutic challenge will help you guide treatments. But it is important also from the other way around, and we have Dr. MC Sharma here, that if you are not very satisfied with the biopsy, you should discuss that in person with your pathologist, and sometimes interactions can help them even look more in depth that they may have transiently not reported or briefed it during the report. So I think that two-way communication is, at least we have learned that here, that we persist and the two-way communication helps us in better judgment of the cases. So that's all from my side.
Thank you, sir.
Thank you so much. Renu, want to add something?
I think it was, I would thank Shagun for presenting this case, and I think we have learned a lot during this session. I think what I understand that these group of disorders should be a differential diagnosis in pediatric age group also. Specifically, rash cases with rash are predominantly seen by rheumatologists, but in the absence of rash, still they can present with the fluctuating weakness. So that's what.
The only other point I would just like to add, of course, I won't take too much time, I know, is that imaging has been progressively being used as a surrogate point to help clinicians judge the presence of a muscle disease. And I'm slightly getting more and more, uncertain about the role of electromyography, because if we don't do that, then how do residents get trained during their training? Because it sometimes may be helpful. It sometimes may be seemingly just to say it's a muscle disease with some spontaneous activity. So I really don't know how to place EMG right now with the new advent of MRIs being used a lot. But I still feel that, these paradigms need to be better defined, because we do have residents and fellows to be trained in electromyography during the course of training as well. So that's another concern. Or, I'm not sure about what to really place it, honestly.
Yes, Rohit, EMG has gone down. Yes, definitely in this cases, imaging has come up in a big way. In any case, I would thank all of you, and thank you, Shagun, for presenting very well. Sorry for having to cut you short. You'll be mailed your certificate. And Mahesh, you want to say something before we wind up?
Yes, as we announced earlier, we'll be having webinars on early alternate medicine now. Next will be on the on 15th of May. We'll be announcing the details on WhatsApp and email for the members.
Yeah, so if you have to register on those links given, now you'll get fortnightly webinars. Now it will not be weekly, but in between we may bring you contextual some other webinars which will be publicized separately. But the SIG webinars will, which were initially weekly, now will be fortnightly. Thank you so much, and see you in Cape Town, whoever is coming to Cape Town. Thank you so much. Thank you, everyone. Bye.
Good night.
Good night.
Good night. Good night.